Good evening, Turkey. Good afternoon, UK, London. And good morning to West Coast. I guess all set?
All set.
Everybody?
So good.
Yeah,
Anywhere in the world can be on board.
yeah, very good. So I am very excited to do this Instagram live. So we were planning this for a long time, and hopefully the new name thing came out, and it's a very good timing, I guess.
Well, it certainly is trendy.
Yeah. So for those of who know me or who don't know me, let me first introduce myself. I am an obstetrician and gynecologist who did my maternal fetal medicine fellowship actually at Mount Sinai. And these were the years where I developed special interest in medical diseases and pregnancy, involved with lots of risky pregnancies, heart disease, liver disease, lung disease. Then after that, I came back to my country after serving for a faculty at Sinai for some time. And I developed many OB departments and maternal fetal division departments. And after years, in the last like 2 years, so I'm now about 60, and I diverted some part of my focus to women's longevity. And I try to got a holistic approach to women's health. And what is LaraHealth is I'm the co-founder of LaraHealth, which adapts a holistic view to women's health like a 360 degrees. And I am very, very honored and privileged to have Dr. Felice Gersh joining us tonight. Also, we're honored that she is a part of our team and she is the scientific lead of our committee in LaraHealth. You know, she's a very well-known person and leader, thought leader in the arena of mitochondrial health, women's health, PCOS, POMS, perimenopause, and mitochondrial health in many ways. So, Dr. Gersh, please let me have the honor to welcome you.
Well, the pleasure is all mine. It's just so amazing that we got connected, and we knew right away that we were definitely a good fit. That we both were thinking so much alike and trying to be very aggressively advancing women's health. You know, we can't just sit back and wait for things to unfold. We want to take the lead and really help to be out there and educating and changing how people think about women's health. And like you said, you know, we've each been through chapters. Like I started out doing loads of high risk obstetrics for 25 years, lots of surgery. I was teaching surgery at USC, and you know, I was involved in all the new devices, every new device that was for surgical advancement, some of which I immediately put in the trash heap. And then it took years before everyone put them in the trash heap. But the bottom line is now I also am focused on longevity, which includes talking about the reproductive years, the adolescent years, even back into the preconceptual years, right? Because it links all together if you're going to have a healthy, long life. So, you know, we're very aligned, and it's my pleasure to be affiliated with you in all these different ways.
Oh, thank you very much. It's a pleasure. So what I did is I just closed the comments part because it's going to be very confusing, but we'll be getting the questions through the YouTube. So our team is now online, or they will help us to lead the questions and transfer the questions to us. And maybe in the last 10 minutes of our conversation, I will open up the comments and we can get more questions. I already got the questions. So today we're going to do like a 101 about PCOS with Dr. Gersh. And let's start. So many things starting to change, starting with the name. But I just want to first come up with the definition. The definition is standard. It's not, has changed. And how do we diagnose PCOS, and what are the diagnostic criteria? You want to come up with those?
Sure. Well, how was this even determined? A committee of doctors. So it's always important to keep that in mind that nature didn't make this decision. A committee of doctors did, and it can be changed, and it has changed and been modified. So understanding that it can be fluid, that it's not fixed in any way, and that it's not written in stone. So it's been somewhat arbitrarily, and there have been discussions. I don't necessarily agree with everything, just so you know. I almost never agree with everything, but it's supposed to be that you have any of the following, two of these. Okay, one would be irregular cycles or even no cycles, as far as talking about the menstrual periods. Another would be that you have androgen excess, but really testosterone excess as the dominant androgen that is in excessive quantities. And then the last one is the ovarian findings on an ultrasound, that you would have lots, and then it was somewhat arbitrarily determined to be 20. I have never seen a single radiologist do a count, I can tell you, I mean, like ever. But they came up with at least 20 of these tiny little follicular cystic structures around the cortex or rim of the ovaries, sometimes alluded to as a ring of pearls, like lots of little circles all around. And that would be where the name came from, for polycystic ovary syndrome. But then they added a new one. So it was 20 of those, at least on one ovary. And then the newest addition was anti-Müllerian hormone, a crazy name. Talk about names. If anything should have a new name, it should be anti-Müllerian hormone, because people couldn't possibly understand what it does in an adult female based on that name. I would say, how about follicle recruitment hormone? But in any case, a very elevated level of this particular hormone would be also now part of the definition.
Yeah, great. And we're seeing lots of patients being diagnosed with PCOS, like 1 in 8. I don't know the exact incidence in the US. So it's about 1 to 8 to 1 to 10. And we have a problem from our colleagues and the patients for the adolescent groups, which is if the patients are between 10 to 20 years old, they try to come up with different definitions, or should they include the ultrasound? Because most of the times the ultrasound findings are not very reliable on those patients. What do you think about that, Dr. Gersh?
Well, I think that is very true. And the definition that I was actually discussing was for adults. So that would be like 20-ish and older, because actually it's very tricky to try to give a definitive diagnosis in a child, say we're talking about, because I consider kids who are 13, 14, 15, 16, they're still kids to me. I mean, they're not adults.
Yes.
They don't have legal status as adults. So in the adolescent years, the teen years, we'll say, the female is going to tend to have more androgen excess, because that's part of the whole the puberty process, which has the adrenergic or adrenal component, and they tend to have more cortisol there, and that goes along with more of the androgen from the adrenal, DHAS. So they tend to have more of the androgen issue, and that's why teen acne is so common as a manifestation. So just having acne is actually not part of the official definition, but when older women, like older meaning 21 and older, and have this like cystic type acne, although it's not part of the definition, it is highly recognized as part of the syndrome. And it's that's not teen acne, so there's a difference. So a teenager who has pimples all over the forehead and lots of little whiteheads, that's actually kind of a different creature. And they're actually, as you mentioned, in a teen year aged person, they tend to have a definite tendency to have lots of little follicles. You can call them trainee ovaries, right? They're still learning how to do it. And that's why sometimes their cycles can be irregular in the first couple of years or so after the first period. Sometimes months go by. So we really have to give it a chance to settle down. However, if you see a young teen female and she has, well, I'll call it trending towards PCOS. She's getting facial hair, she's getting clearly hirsutism. She's gaining weight. She has belly fat, and we know that fatty liver development is not uncommon in young people, in teens, even in children. We need to be aggressively managing the lifestyle of these young women because they are definitely on the path to having PCOS. And it's another very tricky thing because obesity can give a huge similarity in the manifestations, the symptoms that can be very overlapping with PCOS. And it can be tricky because obesity now, I'm sure it's elevated in Turkey, but it's crazy in the US.
Yes.
In adolescence now, it's like never been like this, but obesity can mimic a lot of the same features as PCOS. So in younger people, you should still treat them, but you don't have to label them.
Yeah. So, but unfortunately, the obesity and the insulin resistance is not involved in the definition and diagnosis,
Oh,
right?
no, it
But they
isn't.
play a big role.
Well,
Yeah.
it's almost inevitable that you're going
Yeah.
to have some degree. The reason that they don't always say it's universal is because they're not probably identifying it properly. Because the first sign of insulin resistance is that the body is trying to regulate it through elevating insulin production.
Mm-hmm.
And so you can't always detect it in the same ways at the very
Mm-hmm.
earliest stages. But yes, I think it's, so that's why I'm not a big labeler and compartmentalizer. I like to look at mechanisms. And,
Yes.
medicine is fixated on labels. And that's why often if we just deviate for a second, like in autoimmune conditions, they always want to give everyone a label and sometimes they can't. So they'll call it like undefined connective tissue disorder.
Disorder.
Maybe that's okay. Maybe everything doesn't have to be pigeonholed into every little box,
Mm-hmm.
as long as we're trying to really understand mechanisms and then take appropriate steps to ameliorate both the symptoms and the underlying root cause of the problem, then we're on the right footing here in dealing with these problems.
Yeah, we will definitely dive into mechanisms and the etiology of the problem of the syndrome. But in the last week, I don't know how many like shorts or YouTubes on Instagrams or in the social media is exploding. And if you deem appropriate, let's dive into the renaming debate for a couple of minutes. And what's going on is exactly what are the pros and the cons of this issue about PMOS, which is the polyendocrine metabolic ovarian syndrome.
Whew, what a mouthful, huh? I know. Yeah, I even have trouble. Somehow PMOS doesn't roll off my lips either. Somehow it just doesn't, kind of gets stuck. And I am a little bit concerned that PMOS might get confused by people, just general population and even doctors that don't specialize in this with PMS. It's
That's
like,
right.
that is a real similar group of letters. So, and they're not the same thing. Of course, you could have both, like every lot of other things. But and this has been ongoing apparently for 14 years, this wanting to change the name. And this is sort of kind of a trend in medicine, changing the name of conditions to try to make it have more of an educational function with the name, for the name to tell something about how the condition either develops or manifests or involves what organs. And I have mixed feelings about that because it's a lot of effort and a lot of money, a lot of energy going into accomplishing this goal. Now, I don't think anyone's going to say that PCOS, polycystic ovary syndrome, tells it all about everything that's going on. And there's no way that you could get a name that does tell it all. So let's be real. The new name doesn't tell it all either. So the bottom line is I'm not against wanting to educate. That is actually my goal and has been my goal. And I really love that this condition, I'm calling it PCOS/PMOS because that has been the trend with these name changes. The old name is kept, the new name is added on. So it kind of adds more confusion and complexity, but somebody seems to be happy for it. So the bottom line is that that's what I'm going to call it. And I love that this condition PCOS/PMOS is really getting so much attention right now. I hope it doesn't die away in like the next 4 days, but because the media cycle kind of thing. But right now it's really getting a lot of attention, which is fantastic. But because PCOS doesn't tell what's really going on, but it does involve the ovaries, and that's why they put in ovarian in the new title. And it does involve many different systems. It's a metabolic condition. It involves different endocrine organs in different ways, secondarily, not necessarily primarily. So you wouldn't know like what's the etiology, and it doesn't tell you all those things. So, and I fear that like most every other group of letters, in very short order, no one's going to know what PMOS even signifies or stands for, because that happens. Like if you look at what happened with chronic fatigue syndrome, they said that doesn't really make it sound serious. It sounds like you're just poorly energized, or who knows what, but it's not really telling the story. So they had to put in more complexity, myalgic encephalomyelitis. Nobody I've ever heard says those words. So they made it ME/CFS. But people still, I don't know in your circles, but they still say chronic fatigue syndrome. And the same thing with interstitial cystitis instead of painful bladder syndrome, which now they have IC/PBS. Okay, so so I know the way this goes. Okay, it's like a big flurry of attention and talk, but then in the end, it's just a bunch of like alphabet soup. But you know what? If it helps to get endocrinologists who have been in a lot of ways peripheral to understanding and involvement in this condition, and for many women, they have a limited access to different types of doctors or specialists in this field, and they don't know where to go, and they end up sometimes in an endocrinologist's office, and the endocrinologists are not trained in this condition or in ovarian function and ovarian hormones. Maybe this will open the door to having better education for that group of doctors, and also for OBGYNs as well, to expand the thinking on this entire really complex condition. So I accept that PMOS is here. I love the attention to this condition, but we can't let PCOS go away, because if you want to have the ability to find the research and the books and do all of the things that are necessary, if you want to do research, everything that's in PCOS isn't disappearing. So to have searchability, to search the research, you have to keep the old. That's why they can't get rid of it. So it has to be PCOS/PMOS. And that will also help the many nonprofits, the organizations that have been the advocates for women with PCOS for decades. They work on a shoestring budget. They go out and they lobby to the politicians to get more education, more research dollars, and all of that. They all have PCOS in their names, and they don't have the funds to suddenly rebrand everything they have. It's very costly. It's going to cost a lot of money for everything out there to change the labels, and the insurance world and the electronic medical record systems have to make all these changes for coding and such. It's very costly, and my heart bleeds. My heart really bleeds for the people running the nonprofits who now are faced with this problem of having the name of their organization suddenly changed and like the rug pulled out from under them by a group of well-meaning people who don't really necessarily understand what this can mean on a personal level for these organizations. So I think by keeping the name PCOS/PMOS, I still have trouble saying that, will be helpful for these organizations in terms of like not having to rebrand suddenly, and having searchability that they can be found.
Yeah, we also want to use, as you stated, PCOS/PMOS, because exactly the searchability, when you go to PubMed, try to retrieve like searches, studies, many research areas. So it's under still the name of PCOS. So it's very important. The only positive sign for me is the patients had an understanding of there are cysts on the ovaries. Can they grow? Can they transform into
Rupture.
malignant formation or rupture? That part is maybe solved, but other issues are very important. Well, great. So the most important, I guess, you mentioned about the endocrinology people, but it's also very important for the OB, because as far as I remember from my residency and fellowship, even still, I dealt with lots of curriculums in the OB department of the universities. PCOS has a lacking understanding from a holistic perspective, and every class I took and I gave, we dealt with different pathophysiologic mechanisms, and I am very confused. And I have listened to your lectures at the A4M, many places around the world, and you had a very nice and thorough and clear explanation of the pathophysiology of the GnRH pulsatility, about the testosterone, estrogen deficiency, FSH. Now, let's raise the platform to pathophysiology, and everybody's waiting. What is the real root cause of this syndrome?
Well, we don't actually know that quite yet, but we're understanding it a lot more than we used to. Now, there is a definite genetic link, because we know that if you have a first degree relative with PCOS, then you have at least a 50% chance. So if you have a mother, a sister, a daughter, if you have anyone that's that degree, first degree relative, you have a 50-50 chance that you'll have PCOS to some degree. And it's important when you talk about a syndrome that it does incorporate a variety of symptoms, and it's on the spectrum, that some women have much more severe manifestations, others are mild. 80% are significantly overweight or obese, but yet 20% are not. But yet if you do imaging, whether it's with a CT scan or body composition using bioimpedance, you find that even the so-called lean PCOS women will have excessive visceral fat and fat around their internal organs. So they're not really home free, with that. So what's going on is, I believe, and I keep going back and forth, and I'm not sure, and I'd love your input on this. Is it primarily starting in the brain, or is it primarily starting in the ovaries? And so I was thinking initially, and I still am kind of in that range, that it's actually in the ovary. That's why I think thinking of it as it's every other endocrine organ and not the ovary would be a big mistake. So if you look at the ovaries of women with PCOS, they do not make the conversion. This is like so fundamental. They do not convert testosterone that's made in the ovary properly and adequately into estradiol. So if you think of it as sort of an assembly line, first you are in the theca cells, and they are making testosterone. And the trigger for them to make testosterone comes initially a signal from the brain with releasing hormones coming from the hypothalamus to the pituitary gland, which then produces luteinizing hormone, LH, and that tells the ovary to make the testosterone. Then it goes down the assembly line into the granulosa cells, and there, under the direction of follicle stimulating hormone, which also comes from the pituitary under the triggers of the releasing hormones or factors coming from the hypothalamus to make the FSH. And then you convert testosterone into estradiol. And in order to do that, you have to have activation of an enzyme called aromatase. And so we don't have optimal functioning of aromatase. And so you have this problem where you have testosterone produced just fine. The skill set to make testosterone is completely different than the skill set to make estradiol. So you make plenty of testosterone, but you don't make enough estradiol. Now, if we get to the brain has sensors to estrogen, but it doesn't have sensors to testosterone. So no matter how high testosterone gets, the brain will do nothing. It won't say, oh no, red alert, too much testosterone. No, it will not do that. But if it has sensors and it says not enough estradiol, then it triggers more LH to be produced from the pituitary to make testosterone to be the precursor to estradiol. But you don't make enough estradiol. So these sensors keep saying we need more. So you keep making more and more testosterone, but you don't make enough estradiol. So you end up with, like I call it, like a double whammy, the problems associated with too much testosterone and the many, many problems associated with insufficient levels systemically, body-wide, of estradiol, which is why the metabolic issues are completely synonymous with the metabolic issues that women going into menopause face, but aggravated by the androgen excess issue of too much testosterone. Now, if we get into more the nitty-gritty, well, what is also really important for the production of proper and function of aromatase, and that is myoinositol. So maybe that is more fundamental, okay? Because we know that the ratio of myoinositol to like D-chiroinositol should be 100-1 in the ovaries, 100-1. Now, in the blood, it's usually like a 40-1, but in the ovaries, 100-1. What about in PCOS ovaries? It's more like 12-1. It's a totally appropriate ratio. And D-chiro, now what is inositol anyway? It's a sugar alcohol, and they have what are called stereoisomers. So it's like a stereoisomer, it's the same molecule, but arranged differently in space. So like, here's my hand. Now here's my hand. Now here's my hand. Now here's my, but you know, it's the same hand. It's just like arranged differently in space. That's what the different inositols are. So, but they work differently when it's arranged differently. Okay. So myoinositol can be actually blocked by D-chiroinositol. And so it's like a crazy relationship. You have to have the right ratios of these. And in the liver, you have a different ratio where you have more D-chiro than you have myo. And, you know, myoinositol has a variety of different functions. And one is to improve insulin function in the ovary. So there you go with insulin issues, right? So the ovary becomes like insulin resistant if you don't have enough myoinositol. And it's also critically important for FSH function. So it's like, whoa, it's so complicated. And you need to have FSH to actually have healthy, and you need to have, you know, the eggs, the oocytes. So we know that when you supplement with myoinositol, you actually promote ovulation, better egg quality, better embryo development, successful, you know, pregnancy, you know, to occur. So, you know, maybe the initial problem relates to this imbalance thing with the myoinositol, but then we have that anti-Müllerian hormone issue, like really high. So anti-Müllerian hormone, which that has a crazy name, because in the embryo, anti-Müllerian hormone, it causes regression, like disappearance of certain structures. Like people always know the little human embryo has a tail, right? But then the tail goes away, right? So there's other structures that are there, and then they're not. They like go away, okay? And that's what anti-Müllerian hormone, you know, certain Müllerian structures. But in the adult female, it's part of the recruitment of these little follicles. So, and without adequate FSH, which you don't have adequate FSH being produced by the pituitary, okay? And so, and that gets back to the whole regulatory system with the Kindi neurons, if you want to get into all of that. You know, but in terms of what's going on with the anti-Müllerian hormone, if you need to have a high elevation of FSH to turn off that anti-Müllerian hormone, but it won't turn off because you don't get that higher FSH, follicle stimulating hormone. So you end up having like perpetual more and more anti-Müllerian hormone being produced. It's like, can you please turn the off switch? You know, so you keep recruiting more of these little follicles. It's like they just won't stop. They keep coming, and little follicles come, and the anti-Mullerian hormone is high, and that's what that just messes things up. So you don't get that special. I call it the special chosen one, where when you get the higher FSH, it shuts down the anti-Mullerian hormone. So you don't keep recruiting all those little follicles to come on the scene. And then you get this miraculous thing. It's like the miracle of life, where one, occasionally two, right? You get this one egg that matures and then ultimately ovulates. So the way I look at it, it's like a beauty pageant, okay, an old-fashioned beauty pageant. Okay, we don't really love them, but they're old-fashioned beauty pageant. And all the beautiful women line up and they say, oh, I hope I get chosen. I hope I get chosen. But then they say, no, we pick, this one. And then all the other ones have to leave. Okay. And then that's the one that becomes chosen. So that's kind of all little picky out of the chosen, picky, but only one or occasionally two gets chosen, the first runner up, and then they get ovulated. And that's not happening in women with PCOS. So they don't have regular ovulation, and then they don't make progesterone either. And progesterone has all kinds of other important effects that involve both the brain and the ovaries and everywhere else in the body. So, and then you end up with all this testosterone, and then you have this wild array of problems that are completely all over the body. And then it's hard to know cause or effect, but the sections in the brain that regulate the pulse production, this beautiful rhythm of these gonadotropins, the FSH and the LH, it's all like disarray. It's disarray.
Oh, it's very complex. So that's why we see in daily clinical practice different types of PCOS. The syndrome represents in a different way in all individuals because the mechanism is so complex. But to wrap up, it's very important. You mentioned about the aromatization problem from testosterone to estrogen, which the chiroinositol is very important at that level. And mostly in our patients, we see the LH and FSH ratio is reversed, but not in everybody. Probably that's also one of the reasons from different etiologies. And the brain pulsatility is very important. You mentioned a very important issue. In the lean PCOS, it doesn't mean that they don't have fatty liver or fat around the belly or organs. When we mention about insulin resistance, we always take into account about the fasting glucose, hemoglobin A1C, and the fasting insulin. But I think that it's more than that, because even for the lean ones, if you go for the glucose tolerance test, we may diagnose some part of the patient with insulin resistance as well. Do you do glucose loading or tolerance test for 2 hours to detect insulin resistance? So what's your strategy?
Well, I used to, but I'm not doing that anymore. Patients have been not very cooperative. They don't really want to do that, but I'm not against it at all. Of course, in obstetrics, that's like the standard is that you do that, right? And I always talk about hemoglobin A1C. That is just a very rough surrogate marker because you're looking at glycated protein, essentially, sort of like oxidized protein, which can be occur when you have high levels of glucose, but other things can do that as well. So basically, I kind of assume, based on the fact that when you have PCOS and you have insufficient estradiol being produced, then you will have problems with your glucose transport system. That's like fundamental. So they call them the GLUT system. And so if you don't have optimal glucose transport into the cells, then the cells themselves are not going to have, the adequate substrate in which to create energy. And in addition, this is sort of foundational, that when you have women who have estradiol insufficiency, whether it's because they're going into menopause or because they have PCOS, you will have significant mitochondrial dysfunction. And when you have dysfunction of your mitochondria, then you're going to have a whole array of metabolic problems affecting every organ system, which includes everything related to insulin function. And so when you sort of think about the mechanisms, I sort of treat everyone as if they definitely have a trend, a tendency to have insulin resistance, but fundamentally that they have mitochondrial dysfunction, which then creates a whole array of additional dysfunctions like autonomic dysregulation, gut microbiome dysbiosis, and that you're going to have all of these ancillary things because it takes a lot of energy to run your autonomic nervous system that should be primarily vagal tone dominant, but which they sometimes call it rest and digest. The vagus nerve, it's a 10th cranial nerve that comes down like a finger from the brain and has branches of nerves that go everywhere. And the neurotransmitter, because all nerves have neurotransmitters, is acetylcholine, and estradiol is critical for like really all of the neurotransmitters, including acetylcholine. So there's multiple mechanisms whereby you have autonomic dysregulation. And when you don't have adequate vagal tone, you have a sympathetic overdominance. So sympathetic, think of the S not as, oh, I have sympathy. No, S as in stress. It's the induced state of the neurological system that is supposed to be the response to stress. And stress is supposed to be one of two things: damage or injury, trauma, or invasion of the pathogens, like whether it's viruses or bacteria. And then you get what they call the DAMS and the PAMS signaling, so P as in pathogens, D as in damage, and that will trigger sympathetic upregulation, which is the stress response. And part of the stress response is inflammation, which I think is universal in all women with PCOS/PMOS, that they have a degree of systemic body-wide inflammation. And inflammation will always induce insulin resistance. And when you have higher levels of circulating insulin, it increases insulin like growth factor 1, IGF-1, which can actually migrate into ovaries and directly cause an increase of testosterone. So you have another double whammy. So the insulin actually through the upregulation and production of IGF-1 can directly cause ovaries to make more testosterone. This is one of the mechanisms whereby women who are obese can have facial hair and acne, but it's a different mechanism. This is an aggravating mechanism for women with PCOS, not the primary, but in women with obesity, it's more the primary is that they have the insulin resistance, and then that induces the IGF-1 to increase the testosterone production, and that causes more damage and other things in the obese and aggravation of the women with PCOS to have even more problems. So you have this, state of chronic inflammation and upregulation of the immune system into a pro-inflammatory state. And when you also have what we call the renin-angiotensin-aldosterone system activated into the inflammatory pathway, which then additionally causes vasoconstriction. And then you have more hypertension. And estradiol is critical for the production of this vital gas called nitric oxide that maintains, among a variety of things, vascular health. The lining called the intima of arteries requires nitric oxide to stay healthy. So you don't have that. So you then have damage to your intima. And then estradiol is critical for maintaining the proper function of another enzyme, many enzymes, one of which is called PON1 or peroxidase 1, which helps prevent oxidation of cholesterol. And it's oxidized, or like the equivalent of rusted cholesterol, like oxidized iron is rust, right? So when you have oxidized cholesterol, it can no longer be recognized by the special receptors called LDL receptors on the liver, which, by the way, also require estradiol for their proper function to then pull the old cholesterol back into the liver for recycling or disposal. So the specialized immune cells called the macrophages have to gobble up the oxidized cholesterol in their little envelopes, the apolipoproteins, and then you have these immune cells filled with all this oxidized cholesterol. They look like they're full of suds, so they call them foam cells. And then the foam cells line up along the damaged artery because they're attracted to damage. There's still functioning immune cells that are attracted to the DAMPs and the PAMPs, the damage and the pathogens, and then they can work their way through cracks and fissures into the artery wall and causing plaque formation. And then they can, of course, grow, become unstable, rupture. And that's why, people can get heart attacks and strokes. So women with PCOS/PMOS will have higher risk of hypertension, diabetes. Like by the time they're 40, they have 7 times higher risk of diabetes. And then they get atherosclerosis, higher risk of cardiovascular events. And of course, that links to, the brain as well. Neuroinflammation underlies anxiety and depression, and the other neurotransmitters like dopamine, serotonin, and then from serotonin comes melatonin. Oh, melatonin is so big on ovarian function too. Melatonin has receptors all over the ovary. So if you don't have melatonin, which you never make enough melatonin if you don't have enough estradiol to make enough serotonin. So you can see, whoa, it's so complex. So they should probably call this ovarian complexity syndrome.
Yeah, very complex. And I'm glad that you brought up the inflammation issue, since it's a big thing in the pregnancy as well, because for patients with PCOS who get pregnant, so we see lots of complications, including like preeclampsia, gestational diabetes. In fact, I deal with lots of patients with preterm labor and cervical incompetence, and we do lots of abdominal cerclages. We're going to publish that soon. It's very interesting that in our cerclage group, the incidence of PCOS is about 35%. By some,
Wow.
it's unbelievable. So we have more than 150 patients which we did the cerclages, and about 35% of them, they have polycystic ovarian disease, and because of the inflammation, everything is mixed up. And also the neuroinflammation issue is very important, as you told, because we thought that anxiety and the mental issues, the mood problems were related to just obesity and the metabolic syndrome, but it's completely different. The central neuroinflammation is probably important in these issues. And from my perspective, I don't know, how do you think, even the peripheral insulin resistance is not correlated to ovarian insulin resistance
Oh.
or insulin resistance in the brain? You can have a complete normal periphery, but it can be a completely different mechanism. I don't know what you think about that.
Well, when you think about it, which organs need the most energy? Well, most people know it's the brain and the heart also, and that's another whole story, talking about the heart. But when you look at the ovaries, it's not always recognized that the ovaries are hugely energy dependent. They need lots of energy. So the organs that can show the issue of insulin resistance due to mitochondrial damage can be, much more inherent into like the brain internal structures and in the ovary. And it's kind of this really, fascinating thing is that when you have the mitochondrial damage, then they actually create more inflammation within the ovary. And so it's like, because the damage of the mitochondria, it causes them to release like damaged signals as they start grade, and then that triggers more inflammation that could be very local to the ovary, creating its own set of insulin resistance. And the same can happen in the brain because of their much higher concentration of the mitochondria than in other structures. And they're so metabolically active compared to other structures that they would be more like the first organs that get damaged. So maybe if you wait a while, you'll see the insulin resistance systemically, but it may follow suit a few years later. So, you know, of this high concentration of mitochondria and the damage. And I think that it's so under-recognized that women with PCOS do have these high rates of anxiety and depression. It's very, very, very big deal. And women with PCOS, to my understanding, do also have higher rates of like atrial fibrillation. So they do have the conduction problems in the heart that relate to the energy production as
Yeah,
well.
from the sympathetic, parasympathetic
Right.
this
Right.
dysfunction, and yeah. So I know that you are like a big fan of microbiota, and I like it a lot because in many places and many conditions, there have been microbiotal changes in PCOS, in menopause, in pregnancy, in preterm labor. Even like in the last week, I caught an article mentioning about a special bug that secretes testosterone and can be a cause of PCOS. So I just want to get your opinion about microbiota. Then we will dive into, because we mentioned about many problematic things and patients are following, and we should give them a hope and the
Oh,
solution. Yeah, of course, there is the light in the end of the tunnel. Yeah. So we're going to show them some guidelines or approaches. Don't worry, stay tuned. And if you want to, if you wish these YouTube programs, Instagram Live, please share this knowledge, information, and programs with your loved ones and followers. So it's very important. So let's get into the microbiota issue, Dr. Gersh.
sure. Let me backtrack for 1 second in that, yeah, I mean, when you have vascular disease, it doesn't disappear when you get pregnant. So that's like a really key thing. And when you have inflammation, you're going to damage structures because, you know, you get damage like to the cervical connective tissue. And also estradiol is critical for collagen production and function, which is critical for cervical structure maintenance. So none of this actually is surprising at all, right? When you really understand the mechanisms. And one of those mechanisms that creates inflammation and long-term effects and body-wide effects is the microbiome. And now we know the biggest microbiome is the gut microbiome, but women with PCOS also have abnormal microbiomes of their skin, of the vagina. They even have done placental microbiomes, and they're off in pregnancy when women get complications. And so they have oral microbiome is off. That's why women with PCOS have more gingivitis and gum infections and such. So all the microbiomes are off. And it's, you know, but the gut one, of course, has gotten the most focus and research. And the first published paper on that came out of China in 2014, showing that women with PCOS have abnormal microbiome composition, diversity, and then they get what we call impaired gut barrier or leaky gut. So there's multiple issues with that. And like you said, testosterone, if you have high levels of testosterone, that in itself can alter the gut microbiome that can actually produce testosterone. It's so wild that you can the gut microbiome, they're like factories in there, and they make hormones, neurotransmitters, vitamins. It's like incredible. And of course, they make short chain fatty acids. And when you don't have the right gut microbiome, which by the way, all women who have hormonal imbalance will have an abnormal gut microbiome. They now have published papers showing women transitioning into menopause have gut dysbiosis and impaired gut barrier, leaky gut as well. So, you know, hormones are critical for maintaining the gut microbiome. And when you don't have that correctly being, you know, managed, then this protective coating, this sort of proteinaceous mucoid protector that keeps the lining, which is just single layers of cells, from coming in contact with the toxic chemicals and products and viruses and bacteria in the gut from coming right up to the lining. There's this protective coating, and that dissipates. And so these toxic substances get right up to the lining cells, and they break down the little fibers that are between these cells that are called tight junctions or held tightly together. But the little fibers that hold them together break down, and then they drift apart. And then the toxins inside all of this stuff, the bacteria, the partially digested food particles and such, it can actually pass between these cells because they're drifting apart and they enter the body proper. So that these are called endotoxins or lipopolysaccharides, but the endotoxin, that word just really rings true. And then if you have too much, like if you had extreme amounts, that can be, in say a trauma case situation, they call that endotoxemia, where they circulate throughout the body and can create, vascular collapse. So well, that doesn't happen in PCOS because it's like a trickle. It's a trickle, not an explosion, but that trickle coming through activates the immune cells. Like 70% of all the immune system cells of the body line the intestine, I think is part of our protection from having food poisoning and such. And also they actually act like little detectors, like the dendritic immune cells. They put little fingers between the cells, like a little antenna. What's going on in there, And then they communicate with the other immune cells. It's like the immune system, a topic for another day. So super fascinating. But estradiol regulates the immune system. Progesterone also has a role. It's very anti-inflammatory, calms them down. So this was published back in 1998 that the immune cells of women with PCOS are hyperreactive. So it takes a lower stimulus of this endotoxin for them to react with an inflammatory response and produce cytokines, this inflammatory particles that then spread throughout the body. And that's another contributor to the whole systemic inflammation, and that creates the insulin resistance. And so that's a very, very significant issue, that you get this impaired gut barrier, leaky gut, and the immune cells producing these inflammatory cytokines. And as well, you have the other immune cells. So those are the innate immune cells, like the macrophages, the neutrophils, the mast cells. And then you have the other cells that make antibodies, the specialized lymphocytes that make antibodies, and they make antibodies to the viruses and bacteria coming in. But over time, through a process they call molecular mimicry, they can make antibodies against your own tissue. And that's why women with PCOS/PMOS, they have higher rates of autoimmune, particularly Hashimoto's thyroiditis. They have more autoimmune thyroid because of this leaky gut. So there are ways, and that's, so I always say, because I don't want to be negative, because like you said, it's just like negative, negative, negative. But the first step in solving a problem is you have to understand the problem. Otherwise, you're just slinging mud at whatever. You don't know what you're doing. So by understanding the complexity and the underlying multiple facets of what's involved in what is now PMOS, and that's what they were trying to get at. So I give them lots of credit because they want people to understand this is complex, because when you have stress, activation of the sympathetic, you have an adrenergic component, the adrenal, so you make more cortisol. We can't even get into all of that. And then cortisol has its own effects on leaky gut and weight gain and appetite dysregulation and insulin resistance. So you have all these different complex things, and you have the thyroid gland that can get involved. Estradiol has receptors on the thyroid gland and maintains the receptor function. And then you have higher rates of Hashimoto's thyroiditis and all of this. So yes, it's multi-organ, multi-endocrine kind of a thing. But now when you have even an inkling of what's involved, we can actually then tackle it and actually make things so much better for every single woman, no matter where she is on the spectrum of this condition.
Yeah. And it's also very important to dive into fundamentals, because what we were taught when we were in the medical school, in the residency, is what is the treatment and the best approach to PCOS. So it was like oral contraceptives. Then, in the recent years, to the guidelines, myo-inositol came in. So, in the last like 10 to 15 minutes, maybe we can dive into basics like diet. What kind of diet would you recommend? Any thought about like gluten-free or dairy-free, or increased proteins and fibers, exercise, sleep? And I know that you're an expert in the circadian rhythm as well, stress, waggle tone. And from that, we can combine it to bioidentical hormone treatment approach, which you are a very important expert on, and then wrap up then, and I will open up the comments for 5-10 minutes. We can get questions. So let's show the light and the holistic approach to our patients. So they should be very positive about outcomes of the disease. And one last thing, is PCOS reversible?
I would say it's highly improvable. You know, I'm not sure if reversible is a good word, maybe, you know, but I don't want to say curable, but how about like remissionable? You know, you can put
Yeah.
it into remission. And all the things that you said are all on my, you know, to-do list for all of my patients. So I do want to tackle the gut microbiome right out the gate, because you can't solve any of this systemic inflammation if you don't like plug the leaky gut and fix that. So but it's complex, because it does involve giving healing foods. Now, what are healing foods? Foods that allow the gut microbiome to thrive. So what do they eat? They don't eat fat, and they don't eat, you know, and by eating, I mean fermenting, okay? That's food source. Their food source is fiber, like you mentioned. So, of course, you need to have some healthy fats, and you definitely need to have protein, but many people don't have enough fiber foods, and they're afraid of foods that they call starch. But starch is when it's not refined, like it's not white bread, it's not like white pasta that, you know, you're eating lots of, or sugar foods, you know, cakes and candies, ice creams and such, or chemicals. Chemicals are terrible for the gut microbiome. So processed foods that have all kinds of flavors, colors, preservatives, chemicals, and things like that, they kill the gut microbiome. So we want to stop killing them, and we want to start nurturing them. And so you want to have a primarily plant-based diet. Now, everyone doesn't have to become a vegan with a high focus on plants, but I do encourage people who are open to it to maybe try 6 months, because we know that when you have an unhealthy gut microbiome, some of the animal proteins that contain, for example, choline, carnitine, they actually turn them into a toxic product called TMA, which the liver turns into TMAO. So you really don't want to have a whole lot of animal protein for about 6 months. But if you really can't go vegan, then I call it like vegan light. Okay. So, or like the sustainability diet, where you have 3 ounces, just like more like a condiment, 3 ounces of the healthiest animal protein that you can find, you know, whether it's grass-fed beef or wild fish, or, you know, or free-range chicken or something, the best you can possibly get, but very small amounts, like you put it in a stir fry, you put it on top of a salad, as opposed to a big blob of like meat on the side of your plate. So you want to just mix it in mostly with vegetables and eat across the whole spectrum, because all of these vegetables, and not just vegetables, but legumes like lentils and peas and all different kinds of beans, and grains like buckwheat. Buckwheat is a source of myoinositol. There's actually good data showing how buckwheat is really good for women with PCOS. And millet, and quinoa. So all of these, like unprocessed, you cook them. So I'm not talking about buckwheat pancakes with a lot of fake maple syrup or something. No, this is like cooking it like rice. And for rice, from my understanding, basmati rice is the least sugar prone. And then you have resistant starch like cold potatoes and plantain, greenish bananas that don't even turn at all into sugar. And you want to eat it combined with some healthy protein, which of course can include a little bit, I said, if you must, animal protein, but there's tons of protein in all those plants I just mentioned. And by the way, if you don't have a sensitivity to soy, and you eat organic, whole, minimally processed soy, like soybeans or tofu, miso, edamame, then they actually are great sources of protein. And many of these foods are actually phytoestrogens. Many of the special, like we'll call supplements, like resveratrol and quercetin, they're actually phytoestrogens. It's important to know that. Urolithin A is a phytoestrogen, so they're actually substitutes for actually having estrogen, because they don't remember women with PCOS have an insufficient amount of estradiol. We always have to talk about different estrogens. It's estradiol that they are not making, not estrone. We don't want to talk about estrone's another topic, but that's a different estrogen, and we do not want to have predominance of that estrogen. We want estradiol. So these different phytoestrogens can have like isoflavones, and you have ellagic acid, which goes to the urolithins, and the stilbenes, that's like resveratrol. These are like I call it food as medicine. I know I didn't come up with that term, but it's like so true, because you have, not only do you have these great phytoestrogens, but you have all the minerals and the vitamins and all the building blocks for cell repair and doing all the good things. And I do very much urge people to have what we call time-restricted eating. It turns out that our gut works best in the morning. Our insulin works best in the morning. And there's many studies that show that you can eat the identical food in the beginning of the day versus the late in the day. And you can lose weight if you eat that food in the morning, and you gain weight if you eat the identical food at night. So I always recommend trying to push as much of the caloric intake into the first half of the day. I know that's not how we live, but it's, if you care, they did one study. It was not a giant study in Israel a number of years ago, where they took women with PCOS and they had them eat 2/3 of all their food for breakfast, and then 1/3 for, like, you can call it a late lunch or early dinner, like around 3 o'clock in the afternoon, no snacks. And in a very short period of time, their testosterone and insulin fell 50%. Like,
Wow.
unbelievable. And they started ovulating. And it's like amazing, And when you eat according to this routine, it really helps with your circadian clock. Everything is on a timer, and you have clock genes. And even the microbes in the gut have clock genes. And if you feed them this way, they'll behave differently. They'll produce differently. They're like in their factory production, they'll work better. Everything works better if you push most of your food into the first part of the day. And if you're really, really enthusiastic about this, try to replicate that Israeli study and see how it works for you, because the data was like, mind blasting, that you could, in a short period of time, lower the production of testosterone and insulin just by how you ate in terms of timing. And you can also, when you get more advanced, you can go into multi-day water fasting or fasting mimicking diets that have been shown to be very anti-inflammatory, lower your inflammation markers, improve lipid metabolism, and actually help with gut microbiome composition. So all of those things are really important. If you can exercise routinely, and exercise, there's so much data on the benefit of exercise in PCOS. I'm just going to say PCOS for right now, okay?
Yeah.
I can't say any more letters, okay? But if you exercise in the morning, you're more prone to weight loss, because everything's on magical timer. So that is wonderful. And if you can work your way under guidance, maybe of a trainer, to have high intensity interval training, that seems to be the absolute best for revving up your mitochondria. It's like a restoration of mitochondrial function when you have this regular exercise. And of course, for muscles, you want to do weight training as well, because when you have inflammation, you can actually break down muscle. Things are not so good. And they used to think that women with PCOS would have really great bones because they carried more weight, but that actually isn't true. Once again, inflammation is inflammation everywhere, including in the bones. So it's not good for your bones to have systemic inflammation. So we want to work on all of these things. And then stress, I'm huge on mind-body methods like guided meditations, guided imaging, progressive relaxation, massage, essential oils, and vagus nerve stimulators, and doing everything you can to increase vagal tone and dampen down that stress response, that sympathetic overdrive that people have. And sleep, we didn't talk about sleep, but sleep apnea and sleep disordered breathing is like 300 times more common in women with PCOS. So getting a sleep study to see if sleep apnea is present and then treating it is very important. And then having proper sleep hygiene. I always personally sleep with a sleep mask. If you have even a little bit of light coming through your eyelids, it can dampen the melatonin spike that's supposed to happen at 2 a.m., which is really important. So you want to have really dark and a cool room. You want to have a set bedtime. You want to try to get at least around 7 hours to 8 hours of sleep. That would be like spot on if you could do that. And, try not to have crazy hours on the weekends, if you can. Don't stay up till 3 a.m. on the weekends. It kind of really messes with your circadian rhythm. Sunlight is very good for setting your circadian clock. Estradiol is critical for maintaining the proper function of the master clock that sits atop the optic nerve that senses light and also nutrients. That's why time-restricted eating and timed eating can really help with your master clock, because when you don't have enough of the right timed eating and estradiol, the word that we use is it drifts. So basically, your organs start working in different time zones. It's like you're living in a body that's perpetually jet lagged. And we know that jet lag increases everything bad you can think of. So by getting morning bright sun, and if you can't, you get a light box. So you get bright sun for 30 minutes, or a light box that you get for 30 minutes, 10,000 lux. And then, you repeat it like midday, like get out in the sun and get, it's a wonderful thing. When you get sunlight, there are receptors in the retina of your eye that go right to the serotonin neurons to make more serotonin. And then you feel happier. And then you make more melatonin and you sleep better. That's why people who work in a cube with no light, and there's so many people that work without seeing any sunlight in their offices or anything, they do not sleep well because they're not making serotonin. They're like grumpy and they're not happy. So getting out in the sunlight will help you sleep better, more melatonin, more serotonin. So, all those things are fantastic, for health. Avoidance of toxicities, like, don't eat out of plastic, like duh, but, take out containers with, stuff, food, try not to eat as little outside the home as you can. Entertain in your home, like it's really nice. Like everyone thinks they have to eat out in a restaurant for entertainment, but people can entertain in their home. Then you can control what's in your food. But when you do eat out, try to do something simply, like maybe you just have a salad and you say, put a little bit of meat on top of the salad or something, or, get the vegetables, or, say you're a vegan, even if you aren't, and try to see what they'll come up with. A lot of restaurants are really accommodating to people. And you mentioned like gluten-free and dairy-free. I absolutely recommend both of those. Dairy is kind of pro-inflammatory and increases IGF-1, which can increase acne and testosterone production. We do not need that. And it's like it makes the blood more acid. We do not want that. Only vegetables alkalinate it, so you end up getting your calcium also into your bones. So you definitely don't want to eat a lot of dairy, or preferably none. And gluten, even if you don't have like celiac disease or gluten antibodies, in some people it's a little bit inflammatory to the gut. So nobody dies if they don't eat gluten foods, okay? So I say go gluten-free for at least 1 year. Well, because everything takes time. And then, maybe you could add back, if you don't have gluten antibodies, maybe the healthiest kind of gluten, like organic barley or organic rye, things like that are not like processed foods, but not for a year. So we have all of that. And then you mentioned the hormones. So I have a very simple way of thinking. If you don't have enough of something and it's good for you, why don't you just give it? It's like
we're talking about bioidentical hormones. So the old school was like to just recommend OCs to lower the androgens, basically, and to regulate the cycles, I would say. So how is your approach to bioidentical estrogen replacement? And let's combine it with the supplements. Basically, you mentioned about the inflammation, that's ALA, the NAD precursors like NMN, and we have omega-3s. And even in Turkey, we have separate EPA and DHA, so we can use in different doses, resveratrol, Q10, quercetin. So where do they fit into your daily practice?
Well, they do fit in, and they're adjuncts to the nutritional program. So when you look at some of like the ones that you mentioned, many of them are mitochondrial boosters. And they're also antioxidants, so they're anti-inflammatory agents. So we need to do both. And they actually, when you have something that's a mitochondrial booster, it's also going to be an antioxidant and reduce inflammation, because by getting healthier mitochondria, you'll reduce systemic inflammation and oxidative stress. So things like you mentioned alpha lipoic acid, yes. Ubiquinol is the form that I usually use, which is of CoQ10, coenzyme Q10, like critical for the mitochondrial electron transport chain. And you also like quercetin, you mentioned, which is a very potent anti-inflammatory agent. It helps to stabilize mast cells, which are very much part of the inflammatory response, and we don't want them rupturing and releasing all of their toxic contents, like which includes histamine, but many other products that create even more systemic inflammation, because this is an unwanted inflammation. It's not in response to damage or pathogens. It's just inappropriate inflammation. So we want to dampen down the immune system's response with like things like quercetin, and ALA also will help in regards to reducing the inflammation response. And then of course, myo-inositol, which is a mainstay. I usually use 4 grams a day in divided doses of 2 grams twice a day. And it's, to me, that's like mainstay. N-acetylcysteine, which has its own benefits in terms of glucose regulation, insulin sensitivity, but also as a precursor to glutathione, because when you don't have adequate estradiol, the mitochondrial antioxidant systems, like whether it's superoxide, these enzyme systems involving glutathione, superoxide dismutase, they're not working properly. So these are supplements that can help to restore those things. And you mentioned like NAD plus precursors. Absolutely, but you have to give them combined with other modalities to reduce inflammation, because they're one of the reasons why NAD plus, which is a critical coenzyme that's involved in basically 2 general areas. One is DNA protection and stability. Other is mitochondrial function and energy production. And when you have a lot of inflammation, which is what we talked about, like endemic to PCOS, and you end up, one of the mechanisms of fighting off pathogens is for our bodies to create an enzyme, CD38, from immune cells that destroys NAD+, which is a critical coenzyme for cell survival. Okay? So when you destroy NAD+ in bacteria, for example, the bacteria will die, and they do that by producing this special enzyme, CD38. The problem is that any inflammatory situation will cause the immune cells to make that enzyme and destroy NAD+, and then it's destroying it when you have systemic inflammation inappropriately being triggered because of leaky gut and other things. Then you end up destroying our own NAD+ in our mitochondria, which is a contributor to mitochondrial degradation, which then you can't, that's another trigger. Where does estradiol get produced? The production starts in the mitochondria. That's where steroidogenesis occurs. So it's like a cycle of doom, if you don't get this inflammation down and stop destroying your mitochondria where you produce your estradiol, and also you destroy your NAD+, which is critical for life itself. So you have to give the NAD+ precursors. I usually use NMN. That's my personal favorite. And which is, nicotinamide mononucleotide. And then you want to make sure that you either have a product that incorporates other antioxidants, and you give an anti-inflammatory diet, an anti-inflammatory lifestyle. So remember that animal protein is more pro-inflammatory, okay? dairy is more pro-inflammatory. It's actually an animal product. So that's why the most anti-inflammatory diet is more plant-based, okay? And so you want to do everything to like reduce stress, you know, you want to have calm, you want to have peace, everything, you know, to reduce
Yeah.
that sympathetic overdrive, which it stimulates the inflammatory pathway and so on. So you want to do everything to support your NAD plus production because that is critical. And part of the problem in women with PCOS is their inflammation is destroying through the immune system's response, inappropriate, you know, production of the enzyme that's destroying our own NAD plus. So we need to address that with supplementation plus lifestyle. All these things come together. And of course, you know, there are many other vitamin D has and vitamin K2 has a big role. You know, there's lots of data on that. Omega-3, like you mentioned, of course, is really important. And then, of course, many women need other things like magnesium. They may benefit from more B complex type, you know, because Bs are so important. And then other antioxidants, like you can throw in, you know, a good multivitamin because all the other antioxidants, whether it's vitamin C and vitamin E, you know, they all have a role. So, but you can't give people 200 supplements. I actually named
Yeah.
it. I call it colitis, too many pills. So, you know, so you have to pick your main ones. And then, of course, you know, I use, I don't know if you're using this, I use a lot of butyrate because butyrate is a short chain fatty acid that requires optimal gut microbiome, which you don't have. So I give butyrate for a while to help heal leaky gut. It's a mitochondrial booster as well. And it actually combined to the vagus nerve. So it's actually a vagal stimulator. So I wasn't always doing that. Like it's not in my books because I didn't know it. You have to do.
Especially, yeah, we started to check the gut microbiome a lot in perimenopausal patients and the patients with PCO, even though they don't have any GI problems. And in the PCO patients, we saw a lot of problems and also in the akkermansia. So they have very
Oh, yeah.
reduced load in akkermansia. It's very important for the mucin layer as well. So we just want to throw probiotics. We just want to first check the gut microbiome if we can. In fact, there is tons of information you provide. I'm so excited to have them all. And it's been almost 1 hour, 20 minutes, and I've been getting questions. So if it's okay with you, we just want to go into questions for the
Well,
next 5,
well,
10 minutes. I don't know how.
I'm going to interrupt for 1 minute because I didn't actually touch on it, but you touched on it. So I do give bioidentical hormones. I just want to
Oh,
make sure that
okay.
people know that. So I give it similar to like what I would give to someone in perimenopause. I would give it in a cyclic. I also give it menopause in a cyclic way to create cycles because when you actually, it's one of those catch-22s. If you don't have enough estradiol, then your mitochondria can't be healthy. And then you also won't make, if you don't have healthy mitochondria, you can't make estradiol. So I give estradiol and I give progesterone, and progesterone also downregulates testosterone receptors. So it's also good in that regard. And progesterone is very anti-inflammatory and has its own special benefits. And so I give cyclic progesterone and estradiol. The progesterone is cyclic, the estradiol is consistent. And the reason I don't love birth control pills, although I do acknowledge they're good for preventing pregnancy, is that they are actually pro-inflammatory. They contain progestins, you might call them fake progesterone, that actually can block the production of nitric oxide, which I mentioned is so critical. And they can actually change things in a negative way. And then the estrogen that's in birth control pills typically is one that will turn into estrone, and estrone acts predominantly on one receptor called alpha, which is a more pro-inflammatory type of, because estradiol turns on and off inflammation, it modulates it, and estrone is more like the on switch to inflammation in a simplistic sort of way. And it promotes growth factors in a sort of unbalanced sort of a way. So we don't want that. Now, it does do one very good thing. It will prevent irregular cycles and lowers the risk of adenocarcinoma of the endometrium because it kind of suppresses that whole thing. But there are other better ways, I believe, to do that. But if you need to prevent pregnancy, it could be considered. And birth control pills as a pro-inflammatory kind of a product is well recognized because it increases blood clots. Blood clotting is part of the inflammatory response. Women with PCOS innately have a higher risk of blood clots. And when you add it together, it is indeed additive. So you actually are increasing.
And we have lots
that's
of
why.
patients who were on OCPs who developed or their rheumatoid arthritis and ankylosing spondylitis exacerbated, unfortunately. So it just destroys the autoimmunity. Yeah, it's very important. I'm glad
You're
that
not
you
going to
brought
make
that.
you're not going to make nitric oxide the same, and nitric oxide is key for T regulatory lymphocytes, which help to prevent autoimmunity. So it's all, gets into more complexity. But it also does do one other good thing. It increases sex hormone binding globulin, but so does bioidentical estradiol.
Okay.
And so you can get everything except you will not get protection from pregnancy. And in fact, you'll become more fertile because these hormones will make women more fertile, not less fertile. So, but that needs to be kept in mind for people who don't want to get pregnant. But,
Yeah.
there are other ways to prevent pregnancy. We always want to keep in mind. But I just wanted to make sure that you know that there is a role for bioidentical hormones. And I plan to write some papers on that because I don't think that's in any way common or mainstream, not even in the tidbit.
I mean, after our collaboration, I'm proud to announce that I already started to use, bioidentical hormones in PCOS as well. And even in some patients, without adding the micronized progesterone, by adding some transdermal estrogen, just does the job as well. Yeah. If
Well,
they're
as
cyclic, if they're not,
miracle.
if they're, yeah. So I said that I'm going to open up the comments, but I have lots of questions. So maybe in the last 5-10 minutes, I'll just go over the questions. And many, patients brought the issue about the PCO when they go into perimenopause. It's something positive to have PCO because they have increased AMH, increased reserve. When they will go into menopause, they got advantage of that, or because of the inflammation and many metabolic problems, and on the top of it, perimenopausal problems adds on that issue as well, and it's more problematic.
Well, when you talk about the metabolic issues, this it's sort of crazy, but I went to conferences at the Androgen Excess PCOS Society a number of years ago where they actually said, well, after when you hit menopause, PCOS just disappears. Well, that obviously made no sense. I couldn't believe these people were even saying such a thing because you can't have years of metabolic dysfunction and have higher rates of diabetes, hypertension, all these things, and suddenly it all disappears. The only thing that happens is other women who don't have PCOS start having a lot of metabolic problems, so it all kind of gets blended. But women who've already had this sort of, we'll say, like a head start on metabolic dysfunction, it's a handicap. And that's why one of the reasons that now it is standard of care that every doctor ask a woman, what happened when you were pregnant? Did you have pregnancy complications, preeclampsia, hypertension, all the gestational diabetes? Did you have fertility problems? Because these are red flags for women when they enter into the menopausal transition and thereafter will have much higher rates of metabolic disease states, whether, high blood pressure, diabetes, higher rates of heart attacks and strokes. So it's a red flag. So all of these things that have happened all these previous years as a PCOS lady come back and things get worse because you then lose what estradiol. Remember, you're not in an estrogen insufficient, you're in an estrogen insufficiency, not zero. You're making estradiol, you're just not making enough. In menopause, when the ovaries stop making all estradiol, then you're in bigger trouble, way bigger trouble, because I call it your reserve. You don't have the health reserve because you've already had metabolic problems. So no, I'm sorry to tell you that it's not a good thing.
Yeah, well said. So the second question is about what is your first line treatment for clinical and laboratory hyperandrogenism? Is it like OCP or spironolactone or myoinositol?
Well, first of all, it's really important to know that androgen excess syndromes are not one thing. So and I'm going to call it PCOS. So PCOS is a diagnosis of exclusion. You have to rule out adrenal tumor, acquired or late onset adrenal hyperplasia, a prolactin producing tumor of the pituitary. So there's a variety of things you have to rule out. A testosterone producing cancer, which is unlikely, but there's different things that can produce excess androgens under the umbrella of androgen excess syndrome. So you need to have a full workup. No one should just say you have facial hair irregular cycles, you have PCOS. No, you have to have a full workup to make sure that you don't have these other issues going on, okay? Then say you have just PCOS, say you have defined, your PCOS, okay? Then because if you have like Cushing's syndrome and you have androgen excess, don't want to go there. That's a whole different condition, okay? Has to be ruled out. So we'll say you have PCOS. I do use spironolactone. Obviously not in someone who wants to get pregnant because it's not good. It's a teratogen. It can create developmental damage in the baby. So especially male babies because it's blocking their. So yeah, spironolactone is useful, and it's an interesting drug. It's an off-label use in women with PCOS or for elevated testosterone. But it does help, and it helps with acne quite a bit over time. It does take time. It's not an instantaneous. You got to be patient with spironolactone.
Have you seen any electrolyte abnormalities when the patients are?
I haven't. I do monitor it because it's technically a potassium sparing diuretic. So it's like a water pill, but unlike hydrochlorothiazide, which is a common one out there, it doesn't cause your body to lose potassium. It actually keeps potassium. But I have not seen anyone who gets into like a problem with hyperkalemia that's too much potassium, but it does need to get monitored periodically. And some women will not like it. Some women, they get hypotensive even, or they get lightheaded. So, it's not like a panacea for everybody. That can be useful. In women who have very high, and typically these are adrenal origin, but sometimes it happens even in PCOS. They have really high DHEAS. That's the androgen from the adrenal gland. In some cases, and there are published papers on this, I will give very tiny doses, like half of a pediatric dose, okay, really tiny dose of a steroid, a high potency steroid. But very, I first work on lifestyle and other things first, like stress can also increase the adrenal production of these androgens, but sometimes just short term, and it's not such a high dose that it's suppressing it's not suppressing cortisol production. It's such a tiny dose, but it can make the difference between a DHEAS that would be, say, double the upper, where you'd want it to be. If it's very high, you got to rule out adrenal tumors and things like that. But when you have just an elevation, like I'm not sure what units you use, but if say it's like in the 500s, that's what we.
No, it's high.
That's high, but it's but you rule out it's not adrenal hyperplasia, it's not a tumor. Giving a tiny dose of dexamethasone, very tiny, can actually suppress it down, like say from 500 to 250, and the cycles come back, their acne goes away, and then it's sort of interesting thing. Then I just wean them off of it, like maybe after a year, and often things are just settled down. It's researched, but not researched extensively. But that's because it does help going on spironolactone, but it's not as much as if it's just pure testosterone. And I personally don't use like the finasteride. I don't use any of those, like 5-alpha reductase blockers, which is the enzyme that converts testosterone to the more potent DHT. I personally don't use those at all. I can't hear you.
Do you hear right now?
Oh, I do. Now I do.
Okay. The one question is, do you measure testosterone or you prefer the dried urine test to measure the DHT in the tissues? And they claim that it's much more sensitive for even for patients who have normal to the testosterone. You may have a higher conversion rate to DHT in the tissue.
Well, I don't think we have a good way to measure the tissue levels, but I do recognize that serum levels of testosterone, as well, this applies to using testosterone in menopausal women, right? Or any woman, the serum levels may not accurately reflect the tissue levels. But if you have high blood levels, then they are high, okay? So basically, it's more the other way. If you say are a menopausal woman, and your testosterone blood level is normal or maybe in the 30th percentile or something, that doesn't really tell you what the tissue level is. But if your level is like really high, then guess what? Really high. So I know it needs to come down.
Okay. And one last question, because the questions are pouring, but I am very proud to say that we're going to establish a PCOS, PMOS program school with the guidance of Dr. Felice Gersh, and we'll try to answer the rest of the questions in different webinars, weekly programs. So please tune in and just follow up closely. The last question is about the value of the AMH measurement, and do you have a threshold for AMH? Because sometimes they said that patients don't get the diagnosis of PCOS, like the 2 out of the 3. Do you have a special threshold level of AMH that supports the diagnosis?
Well, actually, I don't, but I know that once you get much above like 3 or 4, you're getting into a high range. And certainly when you get a level like 12, which I sometimes see, it's like that's clear cut. So I look at what would be appropriate for that person's age. And if it's in the neighborhood of 50 to double what it should be for that particular age, then I think it's too high. But I haven't really seen, and maybe you have, an absolute number criteria. So it's a little bit more touchy feely, and I don't directly treat AMH levels,
Yeah.
So I don't, so it's more like interesting, more than something I actually directly treat. But when you really see a high level, that is like a giant red flag that, her little cysts are being pouring out, because that inducer of follicular cyst, or just follicular structures, are really it's out of control. It's just out of control, and it makes me want to give them like myoinositol that very second, because it does help. It does.
Yeah.
I do want to make people understand that it really is a hugely treatable condition. And the conventional approach of just putting people on birth control pills, and typically often now metformin, and now more and more with the GLP-1 receptor agonist, which is another topic because pregnancy is an issue with those drugs. But, and metformin does have some benefits, in terms of that it works in some of the similar ways to some of the other lifestyle things that we do. But the reason that I'm not just as a side note, the reason I'm not a huge fan of metformin is because of planet Earth. I know that, well, you may say, what does that have to do with me? Well, I'm kind of environmentalist. So metformin doesn't break down. It doesn't break down in the body and out the body as metformin. And it actually bioaccumulates in our water supplies and in our estuaries. And it actually is an endocrine disruptor. It's actually an estrogen endocrine disruptor. And there's a lot of published data in the, the world of like environmental scientists, that it's changing the gender of fish and their genitalia of different like aquatic life forms. And that really worries me because this is getting into our drinking water too. And I don't want kids to drink metformin. And we know that in pregnancy, women with PCOS who are on metformin during pregnancy, it didn't do what they thought it would do. It didn't turn out to be a panacea for anything. And in fact, it didn't even prevent gestational diabetes or macrosomia, like oversized babies. It didn't do that. But the babies ended up having more metabolic dysfunction and bioaccumulated more adipose tissue by age 4. And they were more metabolically unhealthy. So I do recognize what metformin can do, but I think we can do better. Do
Yeah.
better than metformin.
Well, it looks like we need to do a series about mitochondrial health and PCOS. So I don't know how to thank you from the bottom of my heart. You devoted a very important part of your Sunday morning to us, to our followers. But this information is very important, very valuable. So we just appreciate your collaboration deep in heart and soul. So these are very important. So I just want to give you the platform for the closing remarks, please.
Well, thank you, Will. It was my pleasure. And it just is so heartwarming when you find a soulmate, as we say,
Thank you.
someone, because so often I feel very lonely out there, advocating for some of the things I advocate for. And I do want to say to any of you out there who were advocating for the name change, I appreciate your concern for, understanding and better educating on this condition. And my real hope is that by changing the name, it's not just going to be pointless, that it's really going to actually somehow or other jumpstart education and research and interest in this highly prevalent condition that affects a significant percentage of reproductive age women. And of course, we know that it doesn't disappear at menopause. So it's so important that everyone be aware of this condition in the healthcare arena and in the patient population, because everyone knows someone with PCOS. And if you walk around and you go to stores and go shopping, you'll see people and you'll start saying, I bet she has PCOS just from, her skin or her hair or her body shape. And, you're going to wish that you could just tell them what to do. But if you have it, I want you to know that we are researching it and understanding it so much better than we ever did. And that there is so much hope for having the longest, highest quality life, and to have babies if you haven't had them, and to have the life that you want. And I don't want this to be negative at all. I want it to be clear that by understanding, we can then come up with better solutions.
Yes, very well said. Well, thanks again. So hope we will meet one more time or do a series in the next future. And thank you for everybody who've been following us, listening to us for the last maybe 95 minutes. So that's a good amount of time. And you're such an encyclopedia, and we're thrilled to listen to you. Thanks for everything. Please follow us in our channels. This podcast has been brought to you by LaraHealth, our education and awareness program. Please be tuned, and we will be with you for your health, education, and awareness. Regards.